to all of you here in attendance. My name's Laura McLean and I'm the chair of this Joint Health Overview and Scrutiny Committee. So I'm going to start by handing over to the Democratic Services Officer Sam, who will read us the housekeeping arrangements. Thank you.
Thank you, Chair. Before we start, there are just a few housekeeping arrangements to mention. Please can I request that mobile telephones and other such equipment are switched to silent mode so as not to disturb the conduct of the meeting. There is no fire test planned for today. If there is an emergency evacuation, please take instruction from the Sheffield City Council staff present. The assembly point is Tudor Square. The meeting today is open to the public and will be streamed live and for subsequent broadcast via the Council's website. You should be aware that the Council is a data controller under the Data Protection Act. Data collected during this webcast will be retained in accordance with the Council's published policy. By entering the meeting room, you are consenting to be filmed and to the possible use of those images and sound recordings for the webcast. Thank you, Chair.
Thanks, Sam. Can I please ask members and officers to introduce themselves? And I'll start on my left here with Councillor Keenan. Thank you.
Hello everyone, and it's nice to meet the new chair. My name is Councillor Eve Keenan and I'm from Chair of Rotherham Health.
And I'm Kerry Grinsell Clinton. I'm the Governance Advisor supporting Councillor Keenan from Rotherham today.
Councillor Dave Knight from Doncaster City Council.
Caroline Martin, Senior Governance Officer from Doncaster Council.
Good afternoon, Jane Murphy, Scrutiny Officer, Barnsley Council.
Good afternoon, Chair of Scrutiny, Barnsley, Mixto.
Councillor Mike Robertson, Chair of the Health Scrutiny Committee for Nottinghamshire County Council.
Good afternoon. My name is David Harvey. I'm Councillor David Harvey, and Chairman of the Health Scrutiny Committee for Derbyshire.
Sam Walstow, Democratic Services for Sheffield City Council.
Thanks everyone. And we've got Alan here sorting out our webcast for us. So I'll just move on to the apologies. I don't think we've got any, have we, Sam?
Chair, we've received no apologies for this meeting.
And then the next item on the agenda is items for the exclusion of the press and public. But again, we've not got any of those this afternoon. So I'll move on to item 4, which is declarations of interest. So I just want to ask whether any members wish to declare an interest in any of the items of business on the agenda. Okay. And then we'll just move on to the minutes of the previous meeting. So I'll take the minutes as in their entirety. And can I ask if anyone has any comments on them? I think that's any matters arising. The minutes that will be published with the papers for this meeting have got a few slight amendments, but it's just a few names that were spelled incorrectly that have been corrected. So they'll be corrected in the final papers for today. And so can I ask members to approve as a correct record the minutes of the last meeting held on the 23rd of July 2025? All in agreement? Brilliant. And then the next item is our public questions and petitions, but we haven't received any this month. So we're going to move on to item 7, which is on the gluten-free involvement report. So if I could begin by asking the officers who are presenting to introduce themselves, please. Thank you.
So I'm Dr. David Crichton. I'm the Chief Medical Officer at the Integrated Care Board.
Sorry, I'm Katie Davison. I'm Deputy Director of Involvement for NHS South Yorkshire ICB.
I'm Lisa Kell. I'm the Director of Population Health Commissioning in the ICB.
Brilliant, thank you so much. So yeah, thank you for coming, and also just thank you because the consultation on this item only ended on Friday and you've turned it around really quickly to send us a presentation ahead of today that you'll be presenting today, so just to say thank you for that. We were just wondering if with the presentation, if you could focus on the key highlights just to give us time for a really good discussion afterwards, that'd be great. But I'll hand over to you for your presentation. Thank you.
Yeah, that's absolutely fine. So the first few slides, I did include some of the sort of background slides, which many of you were at the last meeting, I think, so will have heard some of those. So some of the things like, on that slide, for example, some of the rationale for why we were looking at gluten-free. So if you wanted me to skip through quickly, I don't have to go over that because that's in the paper as well, I think. Similarly, the next slide just gives you some details on what you will have read at the last, in the paper from the last meeting. So where are we now? So at the last meeting, you quite rightly challenged us around the fact that we were looking at doing a 5-week involvement exercise, and you felt that that wasn't long enough. So we left the meeting having heard that, and we've done a 12-week involvement period, which, as you've rightly said, closed at midnight on Friday. And so the paper that you've had that accompanies this item for this meeting gives you all of the sort of the what we've done, but it didn't give you any of the feedback, which is what we've got in the slides, because when I had to submit the papers, we hadn't closed the involvement exercise, so we hadn't got the feedback. Next slide, please. I have just done a couple of slides again just to show the depth of how we've endeavoured to hear from as many people as possible. So this is the many materials that we produced. As always, we've tried to make sure we've got a mix in there between sort of digital first and hard copy opportunities for people to call us, to see us in meetings, that kind of thing. Next slide, please. Similarly, in terms of how people could feed back to us, a whole suite of opportunities, and we've taken feedback in any form that it's come. So you'll have seen in the papers we've included, like Doncaster Council had a conversation about it in one of their meetings, so we've included all the notes from that. So we've taken all feedback that we've had access to. Again, in the impact, in the papers, you'll see that we did an early impact assessment. That there's a new one being done as we speak to make sure we update that following what we've heard from people. But in the early impact assessment, we assessed which of our communities would be most impacted by this, and we endeavoured to make sure we reached out to them and heard their views. And so this one is way too small for anybody to read, but basically gives you a full rundown of all the different ways that we endeavour to distribute all of our materials and to spread the word about the involvement that we were doing. And that's just an example of some of the ways that we've done that. So there's been media coverage in all of the local newspapers and online, and we've attended various events as well. So if I spend a bit more time on what we've heard, so the slides that I sent you at the end of last week were just before the close, so you'll see very slightly different numbers in this one. Gluten-free I don't think has gone up that much. IVF went up quite a bit in the last few days. So we heard in total in the survey from 1,117 people, and quite a significant number, I think it was about 2/3 of those are people who are in some way affected by celiac disease or dermatitis herpetiformis. I think I've probably pronounced that wrong. So next slide, please. Again, the majority of the people that we heard from, 95%, were people who live in South Yorkshire. And then you'll see a slight difference in terms of whether the people who responded are people who have celiac disease or are people who receive a prescription, because obviously there's plenty of people who manage their celiac disease without claiming the NHS prescription, so I think you see that reflected in that statistic there. Next slide. So then we get on to what people's preferred choices were. Overwhelmingly, you'll see there 63% of people said that they would like us to continue providing the gluten-free bread and mixes to the Celiac Society guidelines, which is what we currently provide. Option 1 was to stop providing, except for the people who are most at risk of being malnourished, by not adhering to a gluten-free diet, and that was the second most popular option. And quite a lot of the conversations that we had with sort of the Celiac Society referenced that being their preference if we couldn't continue to provide it at the current levels as well. We had previously got option 4 as potentially our preferred option, which was to continue prescribing for children and young people, but you'll see there that hasn't come out massively as massively something that people support. And then the other option was to provide it to a sort of a reduced level of the Celiac UK guidelines, and that was to do with the increased cost of shopping for people who have to budget for a gluten-free diet. And then in the other section, we had a range of, some people said don't prescribe it at all, and some people were the opposite end of the scale, saying, you know, you should prescribe other things. I think it's probably later on, but there's quite a lot of preference for other models, particularly the model that's used in Wales, where it's a voucher scheme rather than prescriptions. So there's quite a lot of people in the survey responded that they'd like to see something like that. Next slide, please. So in terms of the qualitative questions that we asked in the survey, these give you some idea of what people said to us from those. So the first question of the qualitative nature was about people giving us a reason that they voted as they did in terms of which was their preferred option. So you'll see here that the one that got the most responses was that there would be harmful consequences because of the cost of living on a gluten-free diet. The second most one referenced quote was to do with products being widely available now and prescriptions not needed. So obviously that's the flip coin, side of the coin. That's people saying that they don't think we should be paying for gluten-free products on NHS prescriptions. And then the others are similarly back in terms of in favour of prescribing. So people saying that it's necessary for their health, there are quality and choice issues, some people did agree that we should make exception for children and vulnerable groups. There was a theme around inequality. Then again, we go back to the fact that the NHS needs to save money and we shouldn't be prescribing. And then similarly, a very small number saying that this should be something that people take their own responsibility for. Next slide, please. You'll see there are very similar themes across all four of the qualitative questions. So this one we asked, if the decision was made to reduce the prescribing of gluten-free products, how would this impact on you or someone you know? Again, health and dietary impact was the thing that came out most strongly, closely followed by cost and affordability. And then there were some other themes around access for vulnerable populations, impact and fairness in the NHS, as well as quality of life and emotional well-being. Next slide, please. If you feel this change impacts you more than others, please tell us why. Again, very similar themes, health and dietary needs, financial impact came across very strongly with pockets of vulnerability that you can identify in there, such as pensioners comes out quite strongly, as well as people who live in more deprived areas. And then other things like the impact on the family, vulnerable people, and again, emotional impact and inequality and fairness comes up. And then finally, is there anything else you think we should consider or be aware of? So this is the opportunity for people who felt that the questions didn't ask them everything they wanted to do to give us any other information. But again, the same themes came out: affordability, health and well-being, access, alternatives, awareness, fairness, and then at the bottom there about the system and the cost to the system. Next slide, please. So as I mentioned earlier, whilst we did get 1,117 responses to the survey, we did hear from people in a number of other ways. So the community leader intelligence, we reached out to a number of groups. This was in the work that was led by the Equality Impact Assessment, and we asked if we could come and talk to their community groups. We didn't get a massive uptake from that. So instead of just assuming, making our own assumptions about that, we tried to do a bit of unpicking with the community leaders about why that might be. And for some of them, they felt there were sensitivities in their communities, or for example, the Roma community, it just simply wasn't something. They weren't aware of celiac disease. They weren't aware they could access prescriptions if they were aware of the disease. So it wasn't something that lent itself necessarily to us coming and having a full conversation with their communities about it. But we've put that feedback in the responses because we think it's important that we acknowledge that there are different communities who are in different places with regards gluten-free prescribing. As I said earlier, we made sure we offered people any opportunities to talk to us in the way that they wanted to. So there were a couple of telephone conversations and face-to-face meetings with members of the public. We've included all direct correspondence from citizens and stakeholders in the findings. So in total, there were 16 pieces of direct correspondence that came into us across either letters or emails. And then we ran a couple of focus groups as well. Next slide. So the next few slides summarise the themes that come from both the survey and all of those other mechanisms I've just talked about. But you'll see, obviously, there were 1,117 responses to the survey. They are quite heavily influenced by the survey responses. So the themes are very similar again. So medical necessity and health impact, quite a lot around the fact that this is not a choice. This is something that people have to live with. And prescriptions are their only treatment for the condition. There's nothing else that can be given to them in its place. And there was quite a lot around the importance of dietary adherence and the risks of non-compliance. So lots of people talking about how it impacts on their life because they have to have, 2 toasters in their houses, different workstations to their families. They don't go out for meals. They don't eat at family and friends' houses because of the risk of cross-contamination. Next slide. Then we go on to cost and affordability. A lot, as you would expect, many people talking about how expensive gluten-free products are in comparison with their gluten-containing equivalents. As I mentioned earlier, there were some particular communities who talked about the financial strain on their budgets, pensioners, single parents, low-income households, and some people saying that it would risk them being non-compliant if they had the prescriptions taken away. People talked about it being a bit of a lifeline, even though it is only bread and mixers that they can get. Again, people talking about it helping mitigate the inequality and preventing the difficult choices between food and essentials, obviously at the time of a cost of living crisis. Inequality and vulnerability, very similar, talking about the communities who would be most disproportionately affected by this, as you would expect, by something that is available to buy if you can afford to buy it. Next slide, please. I promise you there's only a couple more. So this one about quality, choice and access. People saying that yes, supermarket options have improved, but access can still remain uneven, and people not knowing whether they're going to go to the supermarket and not be able to get what they want. People talked about having to go to more than one supermarket to get the various different products, and there was also some comments around it being like easy to get white bread, the more unhealthy options from the supermarket, but the ones that are provided on prescription being a sort of a higher grade in terms of their health benefits, because they've got other things in them as well. Although equally there were quite a lot of comments about how awful the NHS prescription ones were as well. Obviously emotional, psychological impact, again a lot of people talking about how stigmatising, isolating, just a difficult life it is to lead as a celiac patient. And as I mentioned earlier, there's quite a lot of support for other schemes. I think a lot of people actually acknowledge that prescriptions probably isn't the best way to help manage this disease, but they talked about other models in other parts of the country and whether there were opportunities to look into those. And as you would expect, questions about postcode lottery and why there isn't national consistency around this issue. And then finally, just to say, the involvement exercise is now closed. As we said, it closed on Friday. Any feedback we get from yourselves today, we will incorporate into our board meeting, the decision-making meeting. Originally, and in the involvement documents, the decision-making meeting was due to be on Wednesday, the 5th of November, but because of the volume of responses that we've received, the board have asked for a little bit longer to consider the feedback and to think about what recommendations we might want to put to them. So it will now be taking place on Wednesday, the 3rd of December at 9:30. And that's everything.
Excuse me, if I could just come in with just a couple of things to pull out, if I may. So just to remind people that gluten enteropathy, which is the conditions we're specifically talking about, affects about 1% of the population. We currently have identified about half of those people. As you have seen by the presentation, we've had national, regional and local media coverage. Now, I think that has helped raise awareness, not necessarily for the right reasons, but in itself that will be helpful in our identifying more people who might not know they've got the condition. I hope we've also proven that, as any good engagement exercise, that we've actually learnt things in that process. So I'm going to pull out a couple of things. I didn't know that Sheffield was the national refractory celiac centre. That was news to me, so we found that out in the discussions we were having. The Wales scheme certainly was identified as something we needed to focus on a lot more, and the team who aren't here today because they're on with the work of looking into that as an option. Also, the relationship with our charitable organisation, so Celiac UK, and they have worked closely with us previously, but the sort of commitment that, independent of the decision we're going to make, that actually a number of individuals who are affected and their families do rely on them for support. So I think, through our listening exercise, I think we've built a bit of a bond with them about how we might continue to work with them. Thank you.
Thank you. I'll just open to questions now if anyone would like to indicate if they'd like to ask anything or make a comment.
Yeah, thank you for the presentation. Very informative, so thank you for that. One of the things I wanted to look at was some of the feedback from the exercise. And there was a bit about feedback from the focus group from Casey. It's at 5.2, page 26 of the agenda pack, or 14 of 15 from your pack. And it talks about the comparative ICBs and numbers of, and that the preferred scheme that you're looking at, which is option 4, for prescribing only to under 18s. There's only 2 ICBs that currently follow that that prescribing process. And so I was really wondering, what feedback have you sought from those ICBs as to the impact, both in terms of the cost saving, but also in terms of any unintended consequence through any sort of adverse effects to not prescribing, i.e. any medical conditions and treatments thereof that may impact the savings?
So we have reached out to a number of ICBs who've considered similar to us. As you say, there's only 2 ICBs at that time, because I think a number of ICBs are going through the same process as us, so there are more, but I don't think they've chosen that option. I think the feedback we've had is the 4 options that were presented to you last time probably not going to be the 4 options that we present to our board, because I think the feedback has come back. For instance, option 3, which was a kind of 3/4 option of what we currently provide. There's not really a justification to sort of support that. So as part of the feedback we've had is, I think we're moving away from that being the preferred option. So yes, we have taken on board not only the feedback we've had locally, but actually sought some, comparison with other ICBs. So as I said, it's been an eye opener for us to think broader than we originally we'd presented to you last time.
Councillor Knight.
Yes, again, thank you for your presentation, very extensive again. Just looking back, was there any geographical analysis of engagement across the South Yorkshire?
Yes, there was, and again, it was one of those things that we were done too late with us closing the consultation on Friday to include it. But I can tell you that we had 288 responses from Sheffield Place, 223 from Doncaster, 90 from Barnsley, 256 from Rotherham, and 167 from out of area. But obviously they're just people who declare that as well, because some people will have selected not to give us that information.
Thank you. Here, how many people responded to the involvement activity, and how does this compare to the estimated reach?
Yeah, as I said earlier, there were 1,117 responses to the survey, and then probably somewhere like 25, something like that, people responded in other ways. I think we're relatively pleased with the feedback that we've received and the level of it. It's quite high in comparison with previous involvement activities that we've run, and also when we've looked and mapped against, there's a number of other ICBs in the country that are either consulting on this now or have done recently, and we've got quite a high response rate in comparison, so we're quite pleased with the number of responses we've had. Also, if you take it in terms of the number of gluten-free patients we've got in South Yorkshire as well, it's quite a high number. It suggests that we've reached quite a lot of them.
Thank you. Just if I can ask you. Oh, sorry, Michael.
Just to supplementary on figures, 90 from Barnsley is very low comparative to others and similar. Do we know why it was that low? Or did we just not, did we follow the same formula? And so my question is, when you talk about reaching out and not having a massive uptake, did you not think of reaching out differently to try and get a reflection from potentially most deprived of the 4 boroughs?
Yeah, I mean, we took the same approach in all areas, and actually we know, for example, that we had some more successes in Barnsley. So, for example, we know that the council helped us push the messages out in Barnsley, whereas we don't always know. Sometimes our colleagues do it and don't tell us, whereas Barnsley council made a point of letting us know that they'd pushed it out there. What I don't know off the top of my head, but I might be able to have a look, is how that equates to the number of patients there might be in Barnsley versus the other areas, but we could look into that and see what it's like in terms of percentage, if that would be helpful. Yeah.
Councillor Knight, did you have a further question?
If I may, please. If you refer to the agenda for today, you've got page 21 or page 9 of 15, whichever. You've got the 4.3 social media reach. Now then, if you can try to explain, please, you've got the chart there and it shows clicks, which I presume is the number of people clicked onto the site. But can you explain engagement and reach to us all, please?
Yeah, of course. Engagement is it's like an equivalent of a click. So it's how many people have either hovered over it for quite a long time, or they've clicked it, or they've done something that suggests that they have engaged with it in some way. So they might have commented or reposted it, or anything like that. Reach is a sort of a figure that they use in social media analysis to look at how far these figures suggest how many people will have seen it, because obviously you don't always open things or hover over things. It doesn't mean you haven't seen it, because you just scroll past it, don't you? So the reach is about how many people should have seen it.
Thank you for the reach was probably the hardest one to initially understand.
Thank you. Any further questions? Councillor Keenan.
Thank you, Chair, and thank you for your comprehensive report and presentation. Has the ICB conducted a cost-benefit analysis of implementing, you're talking about the piloting in Wales, the card, versus reducing prescriptions?
So in the final paper that will go to our board, we will have more details on that. We were lucky that the Celiac UK were heavily involved with that scheme, so they were able to show us a paper that had been published following the implementation of that. It did lack some details about the cost of the scheme and how it was administrated, so that further work, my Medicine Supplement Programme Director, he's looking further into that as he wasn't able to attend today. So it is something we are actively considering if that is an option. But the evidence provided to us wasn't extensive. It didn't give us all the information that we felt we needed before we could make a decision on that.
Yeah. Thank you. And this is close to all of our hearts. What specific mitigations are being considered to prevent widening health inequalities, particularly among the vulnerable groups, and they were identified in the Equality Impact Assessment?
Throughout all of the conversations we've been having, I think we all recognise that protecting the most vulnerable was a key aspect that we needed to, we heard from people, but we needed as a society. It is a difficult one because, as we've said, the rationale for us undertaking this work is because there's a finite amount of money provided to the health service and to us as an integrated care body. So how we spend that money, we are scrutinised in multiple ways. So I think we'd all agree that one of the aspects of this programme of work is deprivation, and the NHS is sometimes leaning into societal deprivation and that. So it is a tricky one for us, and we want to do the right thing, but it's a challenge for all of us.
Thank you. Any further questions, councillors? Oh, so I'll let Councillor Harvey come in because you've not spoken, and then I'll come to you, Councillor Harvey.
Thank you. It's just a quick question. In your findings here, you've said there is no evidence to indicate that a specific racial group is more affected than others. Did that surprise you, or would you anticipate that?
I think it probably would surprise me, if I'm honest, because usually when we do impact assessments, we can quite clearly see that one community group is affected more than another. But when we did do the research, there wasn't a great deal that suggested that ethnicity did affect your adherence or your likelihood to get celiac disease. So, I mean, you'll see we've still reached out to a number of community groups, but yeah, it probably did. It probably did, if I'm honest.
I think there's a big caveat, to be honest, because as I've already identified, probably we're aware of half of the celiacs that reside in South Yorkshire. So there is a hidden number here who we might just not be aware of, and they may come from communities that we haven't identified. So I think we just need to keep an open mind on that. And as I said, one of the commitments I made was that we would continue to raise awareness so that at least people can make a choice if they know they've got the condition. If they don't, then they're likely to be having a diet that's not good for them.
The other thing to say as well is that it's quite a sort of a traditional British diet to be so heavily reliant on gluten products. So I know one of my colleagues spoke to the leader of a Chinese community group in Rotherham at Nottinghamshire, and his feedback was there just isn't that much in our cultural diets that it contains gluten. So I guess if you look at that, the chances of people being diagnosed with celiac is smaller because they don't have the side effects that would make you know that you've got it, and also therefore their adherence to it would be better as well, I guess.
Thank you. Councillor Style.
Yeah, thank you very much for the presentation, very informative. During your presentation and answering questions after do we need to be assured that any decision made will not increase any inequalities? And when we talk about there should be no increase in inequalities, are we taking into risk factor potential litigation? Because potentially, if someone, through a decision that's made, reduces their opportunities and their equality under the Equality Act, potentially there could be litigation in the future. Has that been taken into consideration?
I'm not sure legal challenge outside of a judicial review, or that we knew we'd be open to, and hence why we've been so thorough with our engagement. But every day we're making commission decisions, so I suppose this is similar to other decisions that we make on a day-to-day basis. But I suppose it's a good prompt and something maybe for us to consider. But it hasn't been highlighted thus far. And of course, we are following a number of ICBs who've been through this process, and we're not aware that there's been a legal case with the impact of the decision that's been made.
But as a supplementary, every ICB is looking at it differently, and we've got the potential that we will be following the path that others have gone or our own path. So again, I'm just concerned that if there is anything significant and people see that they potentially could have harm from the decisions that's been made, there's always a potential for litigation, always. So I just need to ensure that it's flagged up and it's dealt with. Have a conversation with some litigation teams.
Any further questions? Councillor Knight.
If I may, please, and just a bit of background first here. In amongst all the information you provide for people for gluten needs and whatever, I see there's a gap in, or I see a gap in the available information for people to find. If I can give you a couple of examples, if I may. There is an app that says, find me gluten-free restaurants, which is not something you promoted. Another one was, I looked at the food box delivery companies like Gusto as an example. They do a gluten-free mixture of, for £25 you can have 4 cooked meals for 3 people for £25. So the cost there is very, very economic. But obviously you've got to cook the food. It's not anything but pre-made. And then again, I looked at also that there's a lot of competition now between Aldi, Lidl, Tesco, Sainsbury's. And Sainsbury's, Tesco is more especially, does do a free delivery service, and also their range of gluten-free is now a full shelf. There's a hell of a lot available there. And the costings difference, e.g. for cakes or chocolate bars, there was very little difference from a standard Cadbury's bar or whoever against a gluten-free label. The only one that does come up with a larger difference was bread. That is the only one that comes up as having the biggest difference, around 5 pence here or whatever. But if you said how many loaves of bread do you eat a week, if you said 1, and the pound difference between one loaf and the other, again, I was asking here initially, do you put any of this type of information available in your guides to people with celiacs?
Yeah, I think actually you've picked up a point that was raised with us. I can't remember whether it was with the Celiac Society or whether it was with another focus group or some people that we spoke to. But there was a suggestion that we could, it might have been when we spoke to the dietitian at the trust. There was a suggestion that we could support people by providing more readily, easily accessible information about, where they could go for gluten-free foods. I think that's a really viable suggestion that we will look into before our report back to the board. There's also dietitian services as well, isn't there, across South Yorkshire? I'll let you tell them about that.
That's right, just write a few notes, because we know we had Nick Trott, who's a specialist dietitian at Sheffield Sheffield Teaching, who raised a public question the last time we came. So we followed it up with Nick and his colleagues, and the dietitians play a key role in supporting people. Now, because it's a medical diagnosis, you are actively, shared that you've got celiac. So along with that is the support and education and information sharing in regards to this. So Celiac UK, as I've highlighted, play a key role in that. We're aware of there is a lot more offer to gluten-free products, but I think equally we knew that some of our most deprived communities, it may be the corner shop that doesn't have the full range. So I think we believe that, but I think there was a lot of challenge back to say just because it's available doesn't mean everybody's got access to that. And I suppose the final bit, which is not something that I would have thought about, was there is a big fear of contamination. So even things are labelled as gluten-free, people who are celiac are quite suspicious about that. And because I said that I'd been, not that I'd led the life of a celiac, but I was more mindful through this consultation to look for things like, what's the availability of cakes that are gluten-free. And that's actually, there is quite a lot out there, but you know, as I said, was highlighted to me, don't necessarily think that that is something that somebody might have trust in. I think you highlighted about some families having two toasters, because the one that was being used for gluten-free products, they didn't want any cross-contamination. So I think we've learned quite a lot about people's behaviours and how they trust sources and that. You know, we know there is much more gluten-free products available now than there ever has been, and there'll continue to be. But as highlighted by other colleagues here, we do need to think about the most vulnerable and the most deprived communities who might not have the same access as others. So, thank you.
Apologies if I'm being a nuisance today. And I looked at the other aspect again about going through prescriptions, and whereby somebody might have something delivered through the local chemist or whatever, a food product. Now, if say for it's delivered on a Friday and it doesn't get picked up on the following Monday, Tuesday, its shelf life is well gone. Had you considered seriously maybe a voucher system, which would be something that could be spent at one of the, well, whatever shop suitable, without products being wasted going through the prescription system, and also the handling that goes through the prescription system? It would eliminate that entirely.
So I think that's part of the, when we talked about the Wales scheme, we are talking about a reimbursement voucher type approach, so that is being actively considered. At the moment, the products available on prescription are just bread and flour products to be able to cook with. I know one of the benefits of the scheme, like the Wales thing, would it give a bit more flexibility for people to take, you know, to supplement their own diet. I think we come back to, it's got to be within a cost envelope that we can afford. So there's always going to be a balance between, you know, providing a service and balancing the books to be able to provide all of the clinical, you know, care that we provide. So as I said, that is actively being looked at, and it will be considered in the final report.
Thank you. Before the committee meeting, having read the appendices of the committee papers and like the write-up of the focus groups, etc., I think one of my questions was about, you know, has enough consideration been given to other models like means testing and the like subsidy schemes, like voucher schemes like the one in Wales. So it's good to hear that's what's come out of this, and I think that would be one of the things that has been picked up from our discussion today. That is, that will be sort of the view of the committee, really, one of the views of the committee, that should be considered as part of the proposals going forward. And I think another theme that's definitely come out this afternoon is about you sort of disproportionately affecting people on low incomes, and our concern for that, and that, you know, we don't want to increase the inequalities, you know, in our respective places. So I think that's definitely something we'd want to highlight as sort of a view of the committee, for sure. Is there anything else that anyone thinks we just need to highlight before we sort of close this item off? No? Brilliant. So I'm just going to read out the recommendations so that we can agree those before we move on. So the recommendations this afternoon were for JHOS to give our views on whether the involvement approach has been robust and contribute our views on the proposals to be submitted as part of the final papers taken by the ICB board on the 3rd of December. Is everyone in agreement that we've done that this afternoon? Brilliant. Thank you so much. So we will now move on to item 8 on the agenda, which is the IVF Involvement Report. And so I'll ask you to sort of do your presentation on that, if that's okay. And this sort of same applies as for the last one. It'd be great to sort of have enough time to do good discussion on this one. Thank you.
Yeah, and we'll benefit with this one in that the first set of slides are pretty much the same because we've taken the same approach. So we can probably skip straight through to slide 9, if that's all right. So if we go straight on to what we hear, because as I said, the approach that we've taken has very much been similar with gluten-free prescribing and IVF, with some very small nuances, such as, you know, we went to food banks and we went to gluten-free cafes, which obviously we didn't for IVF, but we have obviously done a lot more work with the providers and some of the sort of fertility clinics and that kind of thing to make sure they're getting the word out instead. So in terms of what we heard from 1,706 people for the IVF survey, so slightly higher than the gluten-free one. Again, we had quite a high proportion of those are people who are sort of directly affected or kind of indirectly affected by IVF. So you'll see on this slide, the first blue bar is that they've had funded IVF treatment on the NHS. The pink bar is had it privately, the turquoise bar is waiting for it, and the purple one, the biggest one, is this has affected somebody that I know. And then the other ones underneath that are sort of people who work in it, in the services, or are interested members of the public. Next slide, please. Again, the majority of people we heard from live in South Yorkshire, although slightly less than gluten-free, which I think reflects the interest in this and people wanting to give their views. And then the question on which is people's preferred options, you'll see that very significantly 82% of people would like us to continue funding 2 cycles of IVF, with smaller proportions of people saying 0 cycle, or similar numbers, 5% saying both no, move to 0 cycles, or go to 1 cycle. And then there's 8% of other, and again in the other category there were things like we'd like you to fund 3, which is a nice guidance, obviously. So the next slide, again these are the themes from the qualitative questions in the survey. So the first question again was, please explain why you voted for the option that you voted for, and the quite heavily strongest response in terms of theme was people's right to parenthood. You'll see there were 564 people who referenced something along those lines that pulled out as a theme. And then following that, we go on to the psychological impact of not being able to have children, the clinical effectiveness of having more than 1 cycle, inequity comes into this one as well, and then various other things around funding, both from seeing things from both point of view, the people who oppose the cuts because they think this is a good use of NHS money, and the people who are in support of reducing the number of cycles because they feel that it isn't a good use of NHS monies. Next slide, please. We also asked on this one, if we did move to one of the options that offers less cycles than we currently offer, we think that people who have already started their 2nd course of IVF should be allowed to continue. Do you agree with this? 96% of people said yes, they should be able to. And then the graph below that tells us what people's views were in terms of where you are in that 2nd cycle and whether it should be continued or not, in terms of whether you've just had it approved by a clinician, whether you've had it approved and you've got a start date, whether you've got a start date but not yet started, so that kind of thing. Next slide, please. The next, same one, I've gone up, sorry. The next question was, if a decision was made to reduce the number of IVF cycles available on the NHS, how would this impact on you or someone you know? And interestingly, the themes have moved around a little bit with this one, with financial hardship and cost burden being the one that got the most significant number of responses, followed by emotional and psychological impact. And then, as you would expect from a survey where a lot of the respondents say this is about other people that they know, impact on others and family members also comes up quite highly. And then again, as before, followed up by the people who are sort of sitting on the other side of the fence and have got some questions about whether it's a good use of NHS money. And then we go back into the fairness and equality responses. Next slide. If you feel this change impacts you more than others, please tell us why. Again, finances comes top of that. There were some responses about fertility conditions and whether it's fair if you've got a fertility condition that you're being treated differently to someone else in terms of the eligibility for the treatment essentially for that condition. And then some things that came out there around, particularly for women, around age and time sensitivity. And again, emotional and psychological impact and fairness came out there as well. Next slide, please. Is there anything else you think we should consider? So as before, it's the open-ended question that we always end with to make sure we give people the opportunity to tell us anything that they feel our questions haven't allowed them to say. you'll see again very similar themes around emotional and mental health impact, cost saving, right to parenthood, clinical need for more than one cycle. This one pulls in the sort of the risks around private treatment, and then questions about access, equality, and then again societal and policy priorities and cost saving. Next slide, please. As before, we captured voices from people in other ways as well as the survey. We had 3 pieces of feedback from community leaders. Again, it was the same kind of thing. Particularly with this one, there's a lot of communities where IVF isn't talked about, and so the community leaders didn't even want us to go and talk to their communities. They felt it wouldn't be appropriate. So they gave us a bit of intelligence instead from their communities in terms of why it wasn't talked about. So things like, for example, in Islam, there's quite a strong feeling from a Muslim women's group that it's God's will, and therefore, because that's their religious belief, if people do follow up IVF, they don't want to talk about it, that kind of thing. We also got some direct correspondence. Again, we've included them in their entirety. So there were 4 pieces of direct correspondence around this, and a couple of focus groups, and also, as I said earlier, we included the notes from the Doncaster Chamber meeting about this, and further to me having submitted the papers for this, we got a letter from the South Yorkshire MPs with their views about this as well. So you haven't seen that, but I'm happy to share that if people want to see it. Next slide. Again, this is the summary of the themes from both the survey and the other bits of information that we got. And so again, you'll see similar themes, with right to parenthood being the first one. Again, talk about infertility being a medical condition, not a lifestyle choice. Being a parent being a fundamental right. The NICE guidelines, and then quite a lot of emotional language such as deserve a chance and basic human right. Second theme that came out was emotional and psychological impact. There was quite a lot of talk about restricting IVF being emotionally traumatic, and the mental health conditions that it could lead to, such as emotional distress, anxiety and depression. The idea, I think, comes across quite strongly where if you've only got one cycle, it increases the pressure that you would feel for that one cycle to be successful, so there's the mental health risks associated with that. Next slide, please. The next theme was similarly the clinical effectiveness and the need for multiple cycles. So the question mark over why we would go with 1 if NICE is recommending that 3 is the recommendation. Fairness, equity and postcode lottery. There's a bit of misinformation around the postcode lottery, because I think people in some of the feedback seem to think that we would be going to a more disadvantageous position if we move to 1 cycle, whereas actually we are at the moment surrounded by other areas that are 1 cycle. But again, a call for national consistency, and then the point that for low-income families, same-sex couples, and people with specific medical conditions, there's a potential for this to have a bigger impact on them than others. And then, as you would expect, financial hardship. There's quite a lot of comments around it shouldn't be about wealth, being able to have children. And then we've got, next slide. The risks of the unsafe alternatives. So this came up at the Doncaster Council meeting around, IVF tourism, and the risks that might incur. There's quite a lot of comments, and from some of the focus groups as well, around this being yet another way to target women, and in a world where we're supposed to be reducing misogyny, the suggestion that this was the wrong thing to target. Some talk as well about the economy and needing us having low birth rates currently, and us actually needing to increase the number of children that are being born, and then taking steps to potentially reduce it. Eligibility criteria and barriers to access comes up, even though actually we're only looking at cycles, but people do always have their comments on eligibility rules around BMI, relationship status, previous children, and calls for more inclusive policies. And then the final few themes on the next slide. The cost versus values debate. So again, some support reducing cycles for budgetary reasons, but many argue that financial savings are minimal compared to the emotional and societal costs, and that it might be a false economy. Obviously the feedback that I've already given around IVF being taboo or unfamiliar in some communities, and then it comes across quite strongly that people feel that people who are making decisions should have some lived experience. And then the final slide is the same as the last final slide from Gluten-free, just to state that the involvement exercise is now closed. We're here to take your views back into our board meeting, which again has been rescheduled for Wednesday the 3rd of December.
Just a couple of extra things for me. I think we had most strong feelings represented from Doncaster. I had a letter from the Director of Public Health on behalf of the Council, which we've considered. That was followed up by a letter from 10 of the MPs, as you've highlighted, and then Katie and I met with Health Watch Doncaster, who also hosted an evening meeting which we attended and listened to views. So people do feel quite strongly about this topic and their feelings. Thank you.
That's great, thank you. I think I might start with a question, if that's okay. I just wondered, obviously it's a very high response rate, just over 1,700 people. Is that higher than normal for your surveys by quite a way?
It depends on the topic, to be entirely honest. If it's something that does really motivate people, so if we're doing something around cancer, for example, we get quite high responses as well. But yeah, it is fairly high, and I think we've got our providers in the hospitals to thank for that, because I think they've pushed the message out to, like the IVF clinics and all of that kind of thing. And we know it went on their socials as well. And there's big followings around the fertility clinic at STH, for example, on social media. So I think they have all helped to make sure that we get the message out there and incorporate everybody's views. Having said that, there's quite a high response rate. I think it's 316 from people who are just interested members of the public. So I think the other thing with IVF is its potential for you to be a future patient, if that makes sense as well. I think there's probably a lot of younger women who've responded not knowing if this might affect them in the future.
I think the additional thing I'd say is a bit like the gluten. We have, managed to get national, regional and local media interest in this. So I guess in itself that's raised awareness.
Thank you. And just one more quick question on the sort of the process. Obviously the survey finished on Friday and you've had a huge volume of information given to you, which, like you say, is great that so many people have got involved. Had you had more time, would there have been more information you would have wanted to present to us as a committee, or do you feel like you have been able to bring to us what you wanted to? Thank you.
I think the themes that have been pulled out were the themes that kind of we would have expected. I think the more views we got, they still fell into the themes that we'd identified. So although we did have a bit of a flurry at the last minute, they were just mirroring the views that we'd heard before. It was just the volume of people that we heard from.
Yeah, that's a fair representation. We had, I think it was about 60 entries to the IVF one between sort of close of business on Friday and midnight. So, but they didn't. So I manually inputted all of those, and they didn't really change the themes. It was the same kind of things that people were saying. I think what I would say the other thing that we will be taking to our board, but I think it's probably less important for you because you guys are out there talking to real members of the public and your constituents all the time, is that the papers to board will include some quotes as well, so that it brings it to life. It's not just the themes and the statistics. It's about what people have told us and how this will impact on their lives as well.
Thank you. That's great. You mentioned that you got some letters from the MPs. It'd be interesting to see those, just if you were able to share them. Thank you. I'll open up to questions before I'm hogging the microphone here. Thank you.
Just come in. It was a single letter, but 10 MPs have put their name to it. So we just received that. I think it was just at the start of last week.
That'd be great. Thank you. Anyone else would like to ask any questions? Councillor Keenan.
Thank you, Chair. I've got a couple of questions and I'll let other people in and then come back if they've not been asked. What assessment has been made? You mentioned potential mental health consequences for individuals, and I can completely agree with that from personal experience of my daughter, who is sadly at the beginning of this horrendous process. And it is horrendous. It takes so many, not months, years to even get to the point when you get offered your first round of treatment. And I just think you've brought all of that experience in. What assessment has been made of the potential mental health outcomes for our people in Rotherham and South Yorkshire and Derbyshire, etc., when they've only going to get one IVF cycle?
I suppose I'll start off. I mean, we know across South Yorkshire we do have high demand on mental health, services. As a clinician and I'm a GP by background, I've supported many people. There is the disappointment when things, when people aren't successful in this. So I think whether you are successful or not, I think that what comes with the fertility treatment is an anxiety of whether you are going to have a child or not. There's no guarantee within that. So we are mindful of that. It's come through as a strong theme, and I guess mirroring other questions that we've heard this afternoon, we have to show through our engagement process that we are mitigating against any additional increase in services. So as I said, mental health problems are significant across our population. So there's likely to be additional need on the services.
I think some of the feedback that we've also received from the clinical teams within the Jessop's unit and care is how they support couples that are going through the IVF process and the pathway, and particularly the additional sort of emotional distress that this potential change could have an effect on people. And I think that that's something that we have had some feedback from those clinical teams, and it is within that. So as part of the pathway, and you'll know through your daughter that there is counselling available within the service, but they recognise the impact of a reduced number of cycles if that decision is made, and what additional support we can offer them from a commissioner point of view.
Ask a follow-up on that, is that okay before? It just, obviously, you're saying there might need to be some commissioning looked at to see what support might need to be available for women and family members who are affected. But in terms of the cost, say just looking at the cost saving, if this proposal goes ahead, will that then reduce the cost saving? If we're then thinking that there might need to be more support, which then sort of, is that sort of, how does that work if the sort of driver behind this is cost saving?
I think the biggest challenge for the board when we consider this is this a short-term gain for longer-term, kind of negative impact, and that will have to be considered because you're right. We need to be mindful of making a decision that just it pops its head up somewhere else in the health service. Is a challenging time. We've got our 6-monthly review this week around NHS England, and we do receive additional deficit support funding. So NHS England does expect us to balance the books in this year, even though we know that health doesn't work like that. It's our lives that are affected by the decisions we make. So I think it's a good challenge, and it is the thing we're grappling with.
Thank you. So Councillor Keenan, do you want to come back in?
Thank you. What safeguards are in place to ensure that individuals with complex medical histories, such as cancer survivors, can access additional cycles?
So alongside any policy decision that we have as an integrated care board, we do have an individual funding request board, and that considers any exceptionality. So if people have specific conditions or circumstances, then we do receive that, and the panel is open to any representation from clinicians, and we've widened that for, in particular, the IVF, because we have had a challenge in the past 12 months. So our IFR panel is there to consider people who don't fall into the kind of guidelines as they're committed to. So that will be our process to consider that. With regards to cancer, there are separate policies that are in existence for things like egg storage and freezing. So we do have some additional policies that aren't included in the IVF cycles. So there are other aspects that we'd consider for other conditions. So we hope that we are broad-minded enough to consider that not everybody falls into a kind of specific category.
I can just add to that, please. So from a NICE guidance perspective as well, we do ensure that all of our providers, from an IVF point of view, follow that. And there's clearly, very prescriptive guidelines within the guidance for people that might have fertility issues such as cancer or other conditions. And as Dr. Crichton said, we also do have the cryopreservation policy. So people that are facing those complex clinical issues, they would be obviously able to use those policies, but also the cryopreservation right for them to be able to have their eggs frozen.
Thank you. Councillor Knight and then Councillor Stowe.
If I may, if we can go back to where we started with feedback. Back on the 18th of September in full council at Doncaster, Councillor Gemma Cobby gave us a presentation on the IVF and effects around Doncaster. And if you don't mind, if I can just read that confirm that there was a motion given and the cross-party support councillors in attendance voting for the following statements, and this being that the council believes a reduction in IVF cycles in South Yorkshire will create a postcode lottery on health family rights, putting Doncaster, South Yorkshire at a disadvantage to other areas in the country. Secondly, a potential negative impact one failed cycle will have on mental health for the individual, partner and the wider family, which may cost more on health services than offering an additional cycle. And the third point here that came out of it was individuals, couples and families will be unable to afford private treatment and may seek riskier options to safe IVF treatment, e.g., for example, going abroad to clinics, risking unsafe sex with unknown partners, or even doing to the extreme of ordering semen from unknown donors. And I brought that to you because that was the motion that went through Doncaster Council. If I can now move on, if I can, please. May I ask, the success rate, as you show here in the thing, is out of 10, every 10, for example, you show a success rate of 3. Now, if out of that same 10, if they go for a second of IVF, what out of that 10, if 3 have already been successful, what's the success rate out of the second IVF? And bear in mind there'll be 7, sorry.
If I can describe it in percentage terms, I find that a little bit easier. But in terms of success of a live birth from a first cycle, on average, including South Yorkshire figures, but nationally, is around 29% of couples would be successful with a live birth. For a second cycle, that would be within a range of 30 to 45%. But it does depend on a number of factors, including the age of the woman and also any other comorbidities that the woman might have. So I would say on average, probably the difference between 30 to 45% would be the likelihood of being able to achieve a pregnancy with the second cycle.
Thank you. So on the second IVF treatment, the percentage in terms over at the end of the day is higher.
It's marginally higher. I mean, your question just doing the rough maths. So 3 out of 10 of the first cycle ladies will get pregnant. That leaves 7. And then if you calculate proportionally 4 out of 10, it's another 2.5 who will get pregnant on the second cycle. I think that's what you're asking.
Councillor Stowe.
Thank you. Can we be assured that any proposed changes are carefully managed in terms of phased implementation, so nobody who started, I know you've made reference to it in your presentation, but we needed assurances that anybody who started whatever process they're on will not receive a reduction in terms of their needs.
So that's a decision to be made by the board at the beginning of December. So it's a specific consideration that we will make a judgment on.
But will you be making a recommendation to that board
I think
to the effect that nobody suffers a detriment?
From what we've heard, obviously we would hope that we can support that there will be no retrospective. So if you're already in the system, but as I said, that is for the board to make a decision. So I can't make that singly. The recommendation that I think what we've heard from is that would be challenging and would not be deemed fair. So.
Thank you. Any further questions? Councillor Robertson, thank you.
Thank you, Chair. Yeah, very interesting because we're actually going through the same process in Nottinghamshire at the moment, so we've done quite a lot of this scrutiny work already. One of the things that came out and I was very surprised about, because obviously we're looking at potentially reducing Bassett Law's access from 3 to 1 cycle given the offering in the rest of Nottinghamshire. And I was very, very surprised. It kind of goes on from what Councillor Knight was talking about with regards to success rates and things like that at 2nd and 3rd cycles. And I was very surprised at the drop-off in uptake at 2nd and 3rd cycles, given the aspiration of the cost saving. So what are sort of the figures around sort of, sort of impact on cost and possible, impact on the savings you may make if 3 cycles, as per the NICE guidance, was offered, given sort of the drop-off in uptake after sort of a second round and the successes at that point?
I suppose the challenge is when you talk about statistics is this is individuals and families' decision of whether they proceed. If we already talked about the burden of mental health, if you've not been successful and other medical conditions that may coexist. I think we do have to consider individuals one by one in regards to supporting them to make the right decision at the time. I think commissioners, will put the frameworks in place for it to be considered, but it does come down to that clinician and supporting that patient at that point in time. So. We know NICE are reviewing their guidance at the moment because there was a publication about unproven therapies or unproven treatments. So we know that exists at the moment and that will publish sometime in 2026. So we will have to consider that in due course. But, we're basing our decision on what we know now and what the current guidance is. So we're mindful of that as well. So not preempting what they might say as a result of that. I think like medicine, like all of medicine, it does evolve and it changes and new things come along. So, as I said, we're making the decision based on the information we've got available to us at this point.
Thank you for that answer. I don't think it fully answers what I asked, which is, but I understand there's a lot of variables to it. Another thing that I'm very interested in, because this is a piece of work that the ICB in Nottinghamshire have looked at, is with reducing the amount of cycles and looking for savings there, that there's the potential that they could open out the policy of access and make it more inclusive. I don't fully know what the access policy is for South Yorkshire ICB, but one of the key areas we were quite interested to press our ICB on was around sort of blended families where the relationship has a child from the male of that relationship and how that disadvantages the women. So if you did look to make those savings, could you potentially make your access policy more inclusive to women who are currently stopped from getting that treatment?
So in terms of the access to IVF and fertility treatment, we, I think we mentioned it at the last meeting, we do have a policy that's Yorkshire and Humber wide, and that is based on the NICE guidance and HFEA guidance and good practice, and that's developed by an expert panel of clinicians and experts in the field of fertility. And that is complied with by all of the ICB systems within Yorkshire and Humber, and I believe that Nottinghamshire also use, if it's not the same policy, it's very similar, but they used to use the same one. And I think in terms of the NICE guidance is really quite clear about access to fertility, and the policy that we use is based on NICE. So I think for us to deviate from that would be, again, putting us sort of out as an outlier nationally as well. We do ensure that same-sex couples have access to the IVF treatment. So I don't know if there's anything else from a clinical perspective that you want to add, David.
Not really. I think we're on about version 14, so it's reviewed regularly, but we had no intention of changing that through this process. This was purely about one specific element of fertility treatment. I mean, I suppose to go back to your previous question, I mean, because we don't offer 3 cycles, we don't have that data to know the sort of drop-off, because we don't currently have any of our places that have that. And of course, Bassett Law used to be part of the South Yorkshire and Bassett Law system, so we were aware that some of the patients would be treated in South Yorkshire. So I wasn't trying to avoid saying it, but I think we know that if we go back to their 10 people, the more chances you have, the more likely you are to be successful. There's no doubt about that. But not all 10 will, have a live birth at the end of it. So, with regards to the access policy, I think it does allow us to offer it to, it takes into consideration of human rights. It takes into consideration about other protected characteristics. So I feel quite comfortable as a clinician. I think, we do have quite a broad approach. The one element that we always get challenged on is whether you've got a child from a previous relationship, and that's whether either partner has that. That is clear. That has been for many years, and we weren't considering changing that at this point in time.
Thank you. Any other questions? I think I've got a comment and then just a question. I guess my comment would be sort of having read through all the information in the pack, and just that worry about inequalities, and that if this proposal were to go ahead, there are some families for whom they can afford to go ahead and pay for second, third cycles, but there are many families who cannot do that, and they will either choose not to do that because of that prohibitive cost, or there is the risk of people taking on debt or travelling elsewhere to receive treatment that might not be up to the right standards. And so I guess that is my concern, one of my concerns that I would want to share on those proposals. And I guess my question is about if the proposals do go ahead, how will the impact of that change be monitored and considered in the future?
If I could just pick up the bit about health tourism, because as the Chief Medical Officer of South Yorkshire, I think I do have a responsibility to say people need to do their homework. People do travel abroad. It's not just infertility treatments. People go for plastic surgery, bariatric surgery has been quite popular, and so is dental treatment. And the outcome is not always, the service provided elsewhere is not regulated the same way in this country. So, we know people do that, but we couldn't say we support that unless you really do your homework and consider about what the impact of that might be. With regards to sort of monitoring, I mean, any new policy that we agree, I think it's upon us as a commissioner to continue to evaluate the impact that's had. We would be expected to do that, I think. So, as I say, we haven't made the decision yet, and so not preempting what that will be. I suppose we would need to look at how, well, Lisa, you can come in on that.
Yeah, I think depending on what the decision is, what's made in November, we will work closely with our providers and with the clinical teams that care for these individuals, just to make sure, and it comes back to the point earlier about counselling and support, and we will need to make sure that we understand what the impact is going forward if that decision is made to reduce cycles. So it's not something that we'll just step away, and we'll also have to agree with the hospital trusts about the implementation of that as well in terms of timelines.
Thank you. Any further questions? No? Okay. So I will move on to the recommendations, if that's okay. We've been asked to give our views on whether the involvement approach has been robust and contribute our views on the proposals to be submitted as part of the final papers taken by the ICB board on the 3rd of December. Is everyone in agreement? Brilliant. Thank you so much. And just to thank you all for coming today for those two items. Thank you. So now we shall move on to item 9 on our agenda, which is our terms of reference. So I'm going to hand over to Alice, who's just going to present that report to us.
Thanks, Chair. So on page 91, the recommendation is that this scrutiny committee is asked to note the change in text. We've done a little bit of a tweak to the terms of reference from the last time you would have seen it in over a year ago now. Just to clarify the hosting and chairing arrangements, and just ask you to agree this version. The specific changes are, if you go to page 94, under the second bullet point, it originally said the committee will agree the hosting and chairing arrangements. Stop there. And so we've added in there as needed, and then emphasised that, however, as a norm, keeping up the principle that committee meetings will take place in the town hall of the local authority hosting the meeting. The host location of the committee meeting can be in any member authority, but should seek to maximise accessibility for citizens, and that committee meetings will be chaired by the host local authority. So it's just a clarification around hosting. So if I don't know if there's any further questions, but just asking if you'll accept that.
Thanks, Alice. Has anyone got any questions or comments? Okay. Councillor
I would take it into consideration an annual review. Are you going to pull that in?
Yeah, so we can consider that. So I think that is a suggestion that we review the terms of reference annually, and maybe a suggestion would be to do that at the start of the municipal year. Is that everyone in agreement with that? Yeah, brilliant. So we'll add that as a recommendation, and then we're also noting the change in text to clarifying the hosting and sharing arrangements and agreeing the version attached to this report, but with a recommendation that we'll review the terms of reference on an annual basis, preferably at the start of the municipal year. Okay, thank you. And so then we'll move on to item 10, which is our work programme, and again Alice is going to present a short report on that for us. Thank you.
Thank you, Chair. So this is the work programme, page 95 in your full papers. It sets out, it talks about the fact that you had the previous meeting postponed, and then starts to sort of reassess what might be on the work programmes for the next few meetings, obviously today, and then suggesting that the item around Yorkshire ambulance service come to the meeting in January, along with, if it's possible, an update on dentistry, and I understand there's been changes to the contract, so it's about getting a bit of an update on that. So those are the two items proposed for the January meeting, subject of course to that being acceptable to those who need to come along and actually present and talk through, but we'll work on with that. And then the meeting in March will be predominantly around work planning. I think probably for all of yourselves and some of the conversation that's been had previously, you've got a section there headed up future items to scope for inclusion. There's quite a long list there, and I have a sneaky feeling that there might be some others that people want to propose for inclusion. And when they are, I think, if not before, but certainly your meeting in March or sometime around then, we need to firm this up, and firm this up with ICB and other health providers who may need to come and talk to you about some of the issues you've got. So that's, I think it's probably open to...
Yeah, thank you, Alice. Any comments or additions or questions? Councillor Keenan?
Thank you. If you just bear with me, and it's a bit of a preamble first, why I would ask for this. It's about stroke response and aftercare. Recent data from South Yorkshire reveals that average times between the onset of stroke symptoms and 999 call being made is 88 minutes, which is far longer than is clinically safe, despite national campaigns. In Barnsley, where patients are even more likely to self-present late to hospitals, increasing the risk of poor outcomes. And the JSOC will be aware that that Barnsley and indeed Rotherham have recently raised concerns about stroke care. And it's the 5th leading cause of death in South Yorkshire. And it's more frequently here than in most other regions of England, particularly amongst more deprived communities and ethnic minority backgrounds. Given these alarming figures, I would like to know what targeted interventions are being implemented to reduce these emergency response delays and improve public awareness, especially in Rotherham and Barnsley where we've got the issues. Likewise, the hyper-stroke unit in Doncaster, Sheffield and Wakefield, they operate this brilliant 24-hour specialist care. But a lot of patients are coming to us report inconsistent access to the rehabilitation and aftercare. And I mean, taxi drivers talking about their daughters having a stroke whilst pregnant 9 months and waiting for aftercare and waiting for that second appointment. And the data shows only 39% of stroke survivors in South Yorkshire receive a 6-month follow-up, and most are discharged, it seems, without adequate community rehab support. And I really want to look at stroke response care. So that's a preamble, but that's my little argument. Please, can we look at it?
Thank you for that, Councillor Keenan. Has anyone else got any comment to make about that proposal? Councillor Stowe?
Yeah, I'll certainly second that proposal because we've got a waiting time in Barnsley of 15 hours. 15 hours, and that's certainly critical in terms of our more deprived communities. We've got the saying in Barnsley, we'll be right. But unfortunately, that don't work when it comes to health and well-being because people think that it'll just go away when it don't, and the evidence is there. And again, we in half of Barnsley are travelling to West Yorkshire, to Wakefield for support. I've got evidence of that where people I know. They're very good service, and then they're coming back to Barnsley for aftercare, but the point's got to be made that the travel time, again, and the distance from the units that deliver the emergency care, we seem to be disconnected in terms of travel times and opportunities to recover, treat and recover quickly. So I'd certainly like it to be looked at again, please.
Thank you. So we can look to add that to the work programme and go away and talk to the right colleagues about who might want to come and present. And yeah, great. Okay, so we'll add that. Anything else? Councillor Harvey?
Thank you, Chair. One of the things that I feel that we should be looking at is the subject of the fat jabs, as they are colloquially referred to. With the increasing numbers of younger people in particular, I'm concerned about the potential side effects. It seems to be a fairly new drug, and although we hear it's tested, I am greatly concerned at the numbers of people who are taking it without the consequences being properly understood. So because of the huge numbers of people in the UK, and particularly in our area, I think it should be added to the list of things that we should be looking at.
Thank you. Anyone has any further comment to make about that suggestion? No? So, shall we add that as well? Is everyone in agreement? Okay. Brilliant. So, we've been asked to agree the draft work programme, which I think we're all in agreement with. Yeah, brilliant. So the last item is just to confirm the date of the next meeting, which is currently scheduled for Wednesday the 7th of January 2026. And just to confirm, do we wish to continue and have this in the town hall here in Sheffield? Yeah. Brilliant. Okay, thank you everyone for your contributions this afternoon. Thank you.